Hello everyone, welcome to today's webinar. My name is Michael, and in a few moments I'll pass you over to Helen to talk about our topic today, which is covert medications. But first things first, a little bit of housekeeping. As always, we're running a little bit behind you guys, so if you have got any questions, feel free to ask in the Q&A section on the webinar here. We will answer all questions at the end, like I said, just because of a little bit of the delay. And also, these webinars are designed for people with already got knowledge in medication training. This is just to help you further understand your role and what's expected from you. But for now, I'll pass you over to Helen, who will talk a little bit about herself and get the webinar going. Helen, take it over.
Hi, thanks, Michael. Thanks for everyone for joining the webinar today. For those who don't know me, I've worked for PrimeLife for nearly 4 years, and I'm involved in everything medication, including developing new training packages, audits and email. Previously to my joining PrimeLife, I've worked for several pharmacists supporting care homes all over the country, and I think of myself as a people person. I really hope you find this webinar a useful support tool. So today we are looking at covert medications. Covert medications. This statement is taken from the PrimeLife medication policy, the safe handling of medications policy and procedures. Covert medication must not be viewed as routine practice and will require continual assessment and consultation with the prescribing GP. The GP should write a clear statement outlining the medication to be given covertly, and this must be kept in the client's care plan and MAR chart together with an explanation of the rationale for this action. Further consideration must be made as to whether or not the resident has indicated consent or refusal at an earlier stage, while still competent in the form of a living will or advance statement. The alteration of any medicine by crushing, dissolving ECT must only be taken with the formal documented directions from the prescriber and pharmacist and signed wherever possible by those people. Carers should be aware that if a formulation is crushed, dissolved or otherwise tampered with, then the product could be rendered unlicensed. Health professionals must consider the risks and benefits for clients of administrating in altered form against not administrating. So let's go through the bullet points from the NICE guidelines. So health and social care practitioners should ensure that the process for covert medications of medicines to adult residents in care homes includes: firstly, assessing their mental capacity, holding a best interest meeting involving care home staff, the healthcare professional prescribing the medicines, the involved pharmacist, and a family member or advocate to agree whether administering medications without the resident's knowledge, called covert medication, is in that resident's best interests. Recording the reasons for presuming mental incapacity and the proposed management plan. Planning how medicines will be administered without the resident knowing. And regularly reviewing whether covert medication administration is still needed. So, covert or overt. There is often a common misunderstanding around the practice of putting medication into food or drink to make it more palatable, often at the request of the resident. This could be regarded as deceitful and open to abuse unless clear documentation supports the practice in the individual care plan. This is overt administration, and it is a cooperative process that is transparent and open to scrutiny and audit, and by definition requires a capacity to understand what is being done. Let's have a look at a scenario. One of our residents doesn't like the taste of the medication and therefore it is difficult to swallow, and she often refuses the medication. She's asked if it could be sprinkled in her morning yogurt to make it more palatable. She has full capacity. Can we do this? The answer is yes, we can, but it must be documented in the care plan and on the MAR chart. It would be recommended that the medication is not stirred in so it is visible. The resident has full capacity and is aware that the medication is being added to the yogurt. Remember, the resident has the right to make decisions. It is also useful for kitchen staff to be aware of the person who is being given medication covertly and overtly, as dietary changes may be needed. Remember, speak to the pharmacist to ensure that this medication is suitable to be given in food. Covert medication. What's good practice? Staff should have a personalised instructions for each medicine to be given covertly in line with the advice of the pharmacist and/or GP. Information could be added to the email system or the resident profile sheet in the MAR folder. This should be added to the care plan and MAR chart to ensure that all staff are aware of the correct process. If the medication has been added to food, then this should not be left unattended. The risk of other residents having access to food is a very high risk. Each time a medication is administered covertly in accordance with the care plan, it should be clearly documented on the MAR chart. Staff must still observe the administration before signing the MAR chart. Where administration is unsuccessful, this must be documented and any consequences reported to the home manager and the GP in the timescales as agreed at the commencement of the treatment and within the best interest decision. It is important to remember that dignity and respect must be maintained. Again, think about your dignity and respect training. Remember that not all food and drink is suitable to be used as covert medication. Tea and milk can interact with some medications. It is also recommended to use a small amount of food to mix with the medication. This increases the likelihood that the correct dose will be administered correctly. Think about your 6 rights of medication. Covert medication, the general standards. Mental capacity assessment. Establishing the resident lacks capacity for this decision and all practical steps taken to help the person make the decision. The last resort. All other options should be explored. Best interest. All decisions based on an holistic assessment of the impact of COVID medications on the person. Inclusive. Decisions should not be made in isolation. Evidence of a team decision involving those closest to the person and the person themselves where or as far as possible. Transparent. The decision-making process should be simple to follow and clearly documented. Regular reviewed. The necessity must be reviewed formally. Time limited. It's for as short a time as possible. What about the storage of covert medications? Medications should be stored in a way that means they're safe and they will be effective when administered. This is one of the reasons that we document the room and fridge temperatures. All medicines have storage requirements that are specified by the manufacturer. Again, this is the reason why we check the manufacturer's guidelines. In residential care, medicines can be stored for residents in their own rooms or centrally. This will depend on who administers the medications. There is no requirement to store covert medications separately from other residents' medications. However, it is recommended that these are clearly labelled and documented on the MAR chart as covert medications. Some residents will refuse to take their medication. It could be because the medication is hard to swallow, tastes unpleasant, or causes side effects such as loose stools and constipation. Do not automatically presume that the resident needs covert meds. You can usually tell from the person's reaction that they dislike the taste or that the drugs can cause unpleasant side effects. Contact the GP for advice on alternatives. And again, do they have the mental capacity? There are times when a person is more comfortable taking the medication in a particular setting or with the help of certain members of staff. Think about your dignity and respect training when administrating medications. If the resident refuses the medication, we can offer the medication later, but this must be documented with the exact time on the MAR chart, and this does not apply to time-critical medications. Remember, the resident has the right to refuse. It is important to remember to document on the reverse of the MAR chart any results or outcomes if the medication is a PRN or when required medication. Again, do not be tempted to try hiding medication in food. As we've discussed, medication that's hidden in food is called covert medication and needs to be approved and have written consent in place. This should be documented in the care plan and documented on the MAR chart. Think about your MCA and DOLS training when administrating meds. Does the person have capacity to refuse to take their medication? If they refuse, try again later. Remember to document and report all non-administered medications and inform the manager if the medication is refused throughout the day. Try talking calmly to the resident, explaining the importance of taking the medication and how it will help them before documenting it as refused. Remember, documenting all non-administered medications on the MAR chart is just as important as documenting when a medication is given. This information could be really important later. Always remember to wash your hands before and after administrating any medications and use the appropriate PPE. Remember to clean the medication trolley before and after each medication round, replenishing the medipots, the giving spoons and the syringes. Always think about your infection control training when administrating medications. Some additional information for you. On covert medications, these must be documented clearly on the MAR chart and in the care plans. Always observe the medication being taken. Observation is still required to ensure the medication is taken correctly and administered in the correct route. A resident may be refusing to take treatment because they find it difficult to swallow a large tablet or the taste of the liquid is unpalatable to them. Do not presume that this medication should be given covertly. A resident may not understand what to do when they're presented with a tablet or a spoonful of liquid, possibly due to advancing dementia. Again, we shouldn't presume that that medication should be given covertly immediately. PRN medication should be carried forward each month and not routinely ordered. Again, some of our covert medications are PRN medications. And PRN medication is available throughout the day, not just on the medication round. Medication side effects. All the medications discussed today have side effects, including headache, constipation, diarrhea, rashes, sores. To find out more about the medication, check the patient information leaflet inside the medication box, or if you have a BNF, book, or you can look on the EMC website online for all side effects, dosage information and overall advice. Remember to monitor the resident for any changes or reactions that may be caused by the medication, and always report your concerns to the manager. Always inform the supplying doctor or pharmacist if the resident is taking any other medications, including herbal medications, vitamins or supplements, or cold and flu preparations. And remember, if the resident has any allergies, this still must be documented on the MAR chart, even if the medication is given covertly. And that's it for the session today. Do we have any questions, Michael?
Yeah, we've had a couple. First question, can all medications be given covertly?
No. Some medications are slow released or require a certain route. So you would always have to go through your GP, prescriber and home manager to discuss what medications can be given covertly.
Okay. So the question of can I crush a tablet down without informing the GP would also probably be a no?
Yeah, it is. In fact, it's very easy sometimes when we're struggling to give the resident the medication to think, well, if I crush it down and give it to them. What we need to remember is that's not at all good practice, and we can't do that. Some medications, as I said previously, are slow release, so that would just sort of affect how the medication's broken down in the body. So really that person could be getting an overdose of that medication all in one go, rather than it being released throughout the day. So it's always best to check with the GP, get a written consent and put that in with the care plan.
Okay. The last question we've got at the moment is, once the medication has been agreed to be given covertly, can this be changed?
Of course it can. Just because we put somebody on covert medication, it doesn't mean that that's a lifetime decision. We need to review that medication and that resident frequently, and that should all be documented in the care plan.
Okay, perfect. Well, we don't seem to be getting any more right now, so thank you everybody for your questions today, and thank you for taking part in today's webinar. Helen, if they have any more questions, how can they get a hold of you?
Sure, they can call me on 0791 704 5483, or they can email me at helenberridge@prime-life.co.uk.
Brilliant. Well, thank you, Helen, for your time today, and thank you everybody for joining. We'll see
Thank
you
you,
again
everyone.
in 2 weeks' time.
Thank you, everyone. Bye.
Oh, Helen, before we disappear,
Yeah.
one has just come through. One last question. How often would you recommend to be reviewed?
That would actually depend on the resident and the medication. And again, that should be documented in the care plan. Some people can, it depends on their mental capacity. So some people can lose a capacity for a short period of time, and it depends on their illness. So it needs to be reflective of that resident and the medication.
So watch what they're doing, watch how they're taking it, and see if they are showing any signs of wanting to change how they take their medication.
Absolutely, and you know, sometimes people lose capacity because of a short-term illness or a short-term diagnosis. So you know, it may be important that we get that medication covertly, but we still need to follow the processes. And once that short period of time has ended, they've had their medication, you know, they can go back to being given their medication, not covertly, sorry.
Perfect. Well, thank you very much. And thank you again, everybody, for taking part today. We'll see you in 2 weeks.
Okay, take care, everyone. Bye.